Hello and welcome to Adult Foster Care Policy Training and Enforcement Sections video, Communicating with Residents Diagnosed with Dementia. In this video, we will focus on the definition and some of the types of dementia, cognitive, psychological, and behavioral changes, relationship changes, and approaches to avoid and for success when communicating with residents diagnosed with dementia. The ultimate goal is to help a resident live their best life with this irreversible disorder. Let's take a closer look. Dementia is a cluster of symptoms caused by some underlying medical conditions, but not the medical condition itself. Dementia is a decline in mental function, such as memory, thinking, remembering, language, reasoning and problem solving, visual spatial abilities, and social abilities such as attention, and behavior. It is usually irreversible. Dementia interferes with daily life and activities. We'll touch on only a few of the more than 100 medical conditions that cause this cluster of symptoms or syndrome called dementia. A person would be diagnosed with dementia when they display impairment and changes of 2 or more of the areas mentioned above, and the changes are significant enough that they interfere with daily life, likely resulting in needing consistent assistance. As a caregiver, if you find it difficult to interact with someone with obvious signs of dementia, it's okay to feel awkward. What doesn't help is not making a sincere effort to interact. We'll discuss how you can improve communication and interaction later in this presentation. For now, let's take a quick look at a few more types of dementia. Memory brain cell function may diminish and lose structure of connecting nerves in the temporal lobe of the brain, resulting in Alzheimer's disease. According to the National Institute of Aging, Alzheimer's disease is the most common cause of dementia among older people. Understanding more about Alzheimer's and dementia may help explain some of the interactions you may be having with a resident who has been diagnosed. It can also help guide you on what to do or what not to do, or even what to say or what not to say to someone with Alzheimer's or dementia, so your encounters can be better for the both of you. Let's look at a few more of the common types of dementia. Vascular dementia is the second most common dementia caused by decreased blood flow to the brain. Lewy body dementia is balloon-like clumps of protein found in the brain. Symptoms include acting out dreams in their sleep, hallucinations, problems with focus and attention, uncoordinated, slow movement, tremors, stiffness. Frontotemporal dementia is the breakdown of nerve cells and their connections in the frontal and temporal lobes of the brain, affecting personality, behavior, and language. Mixed dementia is a combination of several causes. Huntington's disease, Creutzfeldt-Jakob disease, traumatic brain injury, or TBI, and Parkinson's disease are other disorders linked to dementia. Understanding what is happening to the person and showing compassion and empathy during times of frustration when trying to communicate and it's not working. It's helpful to be able to put all of the symptoms being displayed into context and recognize the disease. What the person is doing, how they're acting, what they are saying, the way that they're treating you, their lack of empathy or lack of understanding in the situation is not things the person is doing on purpose. They generally don't look different, so it's easy to forget that they're living with this syndrome. According to a 2018 study in the Journal of Biomedical Science, Social interaction is vital to people with Alzheimer's, as it can improve memory loss by increasing the ability of nerve cells to communicate with each other. By contrast, a lack of social interaction can accelerate memory loss and cognitive decline. However, communication can become increasingly difficult with a resident diagnosed with dementia due to the cognitive changes and the psychological changes that do occur. The symptoms vary on the cause, and here are some of the more common symptoms. Cognitive: memory loss, which is usually noticed by someone else. Problems understanding or finding words. Trouble with visual and spatial abilities. Problems with reasoning, abstract thinking, problem solving, and performing familiar tasks. Primary and secondary language confusion. Trouble performing complex tasks. Misplacing items and then believing someone took them. Trouble with planning and organizing. Poor coordination and control of movements. Confusion and time and place disorientation. Difficulty filtering out background noise, clutter, and distractions. Repetition of statements, questions, and stories. And here are the psychological changes. Personality changes, poor judgment, changes in mood, depression, anxiety, agitation, inappropriate behavior, loss of initiative, being suspicious, known as paranoia, seeing things that aren't there, called hallucinations, and frustration with communication isn't working. One of the biggest or most concerning changes is behavior, which refers to an out-of-character response. It may be a symptom of a disease. Behavioral expression is a form of communication and an expression of a need. Behavior doesn't just come out of nowhere. Understand the resident's environment and triggers to improve your communication and figure out what's behind the behavior that's being displayed, such as restlessness, anxiety, agitation, or aggression. Try to get to the root of the situation. Are they trying to remember something or need something? Repetition of movements or statements. Shadowing, which is needing to be with the primary caregiver and worrying if the caregiver is not right there by them or in their sight. Depression or sadness. Social withdrawal. What may be triggering these behaviors? Is there a photograph displayed reminding them of a loved one and causing sadness? Paranoia, or thinking there is suspicious behavior going on. The person is perceiving what's happening in their environment differently, and even though they themselves put away or hid the item, they've forgotten, and they perceive that someone took it. Confusion, disorientation, or wandering. They feel they should be doing something, but they're lost. Disinhibition, which means saying and doing things that are socially unacceptable or inappropriate. Refusing assistance, like bathing, medications, or general help. Sleep disturbance. It's not uncommon to have a bewitching hour where the individual acts out in a dream or awakens to hallucinations. Or sundowning, which is a behavioral expression that becomes more severe in the late afternoon and early evening. Moving on in our discussion is a resident's awareness of his or her diagnosis. The resident may initially be aware something isn't right, but as the syndrome progresses, self-awareness also diminishes. We'll first look at awareness. Initially, the resident may be aware of memory loss or deficit, and the response to this is usually anger and an attempt to control the situation or self-preservation. They'll say things like, "Stay out of my business. Stop touching my things. I'd be able to keep track of my things better if you don't touch them." They may be anxious and need reassurance. They may ask lots of questions, trying to make sense of the confusion. As a caregiver, you can change their attitude by redirecting thoughts. Also, avoid arguing and drawing attention to the deficit. Stay connected. Don't shy away from visiting or assisting the resident because they're ornery. Don't point out or try to fix what's wrong or finish this person's sentence. Build a team that the resident knows and can trust in case you can't be there during a crisis. Be gentle. Maintain a resident's sense of value and purpose. Keep the resident's skill set in mind. Now let's touch on unawareness. This is the resident can't see their deficit. A deficit of self-awareness is a person suffers some disability and seems unaware of the existence of the disability. So your goal as a caregiver is to change their attitude. For example, they may demand to drive to the store. Instead of saying, "You can't drive anymore," with kindness and empathy, respond saying, "Someone else is driving now." Another example, the resident might say, "I don't like this food," but you as the caregiver know that it's their favorite. Your response is, "Okay, I'll go see what else we have." Then bring back the food rearranged differently and say to the resident, "I know this is your favorite and it's on a blue plate just the way you like it. Is this okay?" The resident doesn't recognize their attitude. They're not in denial or hiding things or even trying to cover up. They truly do not remember and cannot see their deficit. They believe that they're communicating and functioning normally. Because they're unaware of the existence of the disability, they may ask the same question several times, unaware that they've already asked before. As a caregiver, stay positive and answer the questions as many times as asked, refraining from saying, "I just told you," or "You already asked that question," etc. Show empathy, kindness, and patience. Now that you have some background on what dementia is and how it can affect a resident's communication skills, what can you as a caregiver do to communicate and assist a resident with dementia? Let's talk about some ideas. One way is to be aware of the changing relationship as the syndrome progresses. The resident cannot change what's happening in their brain, so you as the caretaker must make the changes in the way you react and interact with the resident. For example, take blame and apologize even if it's not your fault. "I'm sorry, I should not have said it that way." Or, "Oh, I forgot." As a caretaker, you are the one that must adapt and change your responses. You and the resident are changing. Theirs cannot be controlled. Look for things that haven't changed. What does the resident like to do that they've always liked? Redirect them with music, jokes, movies, looking at pictures or magazines, taking a walk, or just visiting. Focus on the feelings and not the facts. Validate feelings by agreeing, reassuring, and with understanding and empathy. For example, you told the resident at breakfast that you will come to pick him or her up for a doctor's appointment at 10 a.m. You arrive to take the person to the doctor's appointment, and the resident states, "I'm not going." Recognize that they're feeling out of control of their time. "Oh, I'm so sorry. I thought I told you about this. But no worries. We have time for you to get ready and to keep the appointment." Use more yes and less no. "Yes, and I agree with you, broccoli's not my favorite vegetable either. Then reassure with understanding and empathy. It's a gentle redirection, such as, should we try it with butter? The resident may ask the same question over and over and over, but to them it is the first time. Answer each and every time with kindness and calmly. And if you're feeling overwhelmed, take a break. Model effective communication one step at a time. If the resident's words fail, it may come out as a behavior. For example, they may be showing worry or anxiety, asking when a loved one that passed will be home. Reorient and be kind instead of answering directly. Say something like, you must really miss him or her. What's your most favorite memory? Keep in mind, communication is more than just the words you use. Your tone, facial expression, posture, body language and movement, physical interactions, and behavior are all part of communication. Infusing your communication with positive body language and respect with genuine warmth will increase the odds of success while communicating with a resident with dementia. The great challenge is to stay present, empathetic, and patient. Approaches to avoid. Distractions. Make eye contact and give the resident your full attention. This also ensures that you have the resident's full attention. Ignoring the resident. Make time daily to check in, say hello, or ask if they need anything. Avoid treating the resident like an infant or child and speaking down to the resident. Also avoid using elder speak, which is a sing-song, high-pitched tone. Avoid using terms such as hun or sweetie. Avoid asking too many questions or interrogating. Instead, ask one question at a time and give the resident time to answer. Avoid challenging their memory or giving too much information. It's easy to explain the whole day, which is too much information. Instead, give one task at a time, such as, don't forget your sweater. Avoid talking loudly. Memory loss is not hearing loss. Avoid using slang or figures of speech, as this can cause further confusion. Avoid showing your frustration. It can be exhausting caring for a resident with dementia. If you get overwhelmed, take a break. Avoid reminding the resident of their memory issue or trying to reason or argue. Remember that their world is not the real world. Avoid taking it personally if they don't remember or recall. They truly do not remember and need that extra compassion from you. Know your residents' triggers and avoid pet peeves. Avoid interrupting or finishing their sentence, as it causes more confusion and frustration for the resident. In the article, Do's and Don'ts of Communication in Dementia, the author states, you can't control memory loss, only your reaction to it. We touched on some approaches to avoid. Let's focus on communication approaches for success. Be respectful and speak to the resident, not to others about them in their presence. Pay attention to your nonverbal cues. Keep your face and body language relaxed and positive. The resident may react to negative body language with aggression. Keep a kind and even tone and never raise your voice. Speak clearly, use eye contact, and have a genuine smile. Be patient, calm, and empathetic. Respond to the feelings being displayed, not the words. For example, the resident may say in frustration, "Someone's always moving my things." Focus on the feeling. You may say, "I agree it is frustrating when we can't find something. May I help you look for it?" Always accept the blame when something's wrong, even if it isn't your fault. Using the example above, you may say, "I'm sorry, I moved it over here so that you would have room to work on your puzzle." Distract the resident by either changing the subject or engaging him or her in simple tasks. Give short, one-sentence explanations. Repeat those easy-to-follow instructions or sentences exactly the same, and allow plenty of time for comprehension. For example, "Would you like eggs or waffles for breakfast?" If no response, ask again the same way, because changing the question makes it a whole new concept to the resident. Avoid insisting if a resident doesn't want to do something. Leave the room if necessary to avoid confrontation. Take deep breaths and count to 10. Come back in a few minutes and try again. Reassure the resident that everything is okay. Practice 100% forgiveness. Remember that memory loss only progresses. We've mentioned that a resident diagnosed with dementia may experience a different version of reality than the real-world reality. They may see things that aren't there, hallucinations, or paranoia. Also common is confusion, along with time and place disorientation. As a caregiver, should you tell the resident the truth or go along with the altered reality? An article in Daily Caring explains why it's better to use therapeutic fibbing to avoid unnecessary distress. So what is therapeutic fibbing? It's a method of dealing with the anxiety experienced by many people with Alzheimer's and other dementias by telling a fib in order to avoid increased anxiety and agitation. It simply means agreeing or saying things that aren't true to avoid causing someone unnecessary distress and to make them feel safe or comforted. Therapeutic fibbing may be used to validate the resident's feelings and reassure them. Telling the truth, especially in an emotional subject such as missing a loved one that passed many years ago, is more likely to cause unnecessary distress and confusion. Additionally, telling the truth each time the resident asks forces him or her to relive the anguish of losing the loved one. Here are a couple examples to consider the resident's reaction based on telling the truth or fibbing. A resident believes she is a young schoolgirl and her mother is picking her up. She needs to wait outside. Do you tell her that she's not a schoolgirl and that her mother died many years ago? Or do you affirm her feelings and distract her with a snack or other activity? Here's another example. A resident believes that he's supposed to be leaving for work and he's very late. Do you tell him that he doesn't have a job and he retired years ago and remind him of his memory loss? Or do you validate his feelings and redirect him to get a jacket or go make a snack? Always follow your agency's protocol concerning honesty and therapeutic fibbing when dealing with the resident with a different version of reality. Thank you for watching our presentation, Communicating with Residents Diagnosed with Dementia. We've given you a few tips, ideas, and examples for communicating and providing the best life for a resident diagnosed with dementia. On the next slide are additional resources for you to further explore the topic. To complete the quiz, click the link below the video. Check back often for additional training videos for the adult foster care providers.